Hi, I'm Emily Littlejohn, the director of the Lupus Clinic, and I'm here to share with you an ever-evolving lupus case. NK is a 25-year-old female with asthma and sleep apnea. In fall of 2015, she was diagnosed with systemic lupus erythematosus based on discoid lupus lesions, a positive ANA at a titer of 1 to 1280 speckled, anti-Smith antibodies, borderline double-stranded DNA antibodies, and low complements. She was initially placed on hydroxychloroquine for her discoid lesions, shown here in this picture, and she did very well. In December of 2015, she developed fevers, tachycardia, elevated liver enzymes, and shortness of breath. This led her to the emergency room. She was admitted to the hospital with acute respiratory failure requiring intubation. Chest x-rays showed bilateral alveolar infiltration concerning fellow alveolitis. She underwent an extensive workup, which included bronchoalveolar lavage, which was negative for certain organisms in her whole infectious workup. This included blood cultures ×5, histoplasma urine antigen, an RSV panel, fungal battery, HSV throat exam, and Aspergillus galactomannan. Her rheumatology labs were as follows. Her white count was low at 1.02, hemoglobin also low at 9.5, and platelets low at 85. Her creatinine was 0.77 with elevations of the AST and the ALT. Her double-stranded antibodies and her complements were within normal limits. Also, as you can see here, she had frank elevations of her inflammatory markers. Her SUD rate was 40, CRP elevated to 7.6, with a high haptoglobin and a high LDH. Also notably, she had high ferritin, elevated triglycerides, elevated IL-2 receptor, and low NK cells. Her disseminated intravascular coagulation panels were suggestive of DIC. Subsequently, hematology was consulted and she underwent bone marrow biopsy. The bone marrow biopsy showed mildly hypocellular bone marrow with trilineage hematopoiesis, increased megakaryocytes, and dyserythropoiesis. She was subsequently diagnosed with macrophage activating syndrome. She was given high-dose IV methylprednisolone for 5 days with swift resolution of her symptoms. Also, her labs started to improve. She was then started on mycophenolate mofetil, 1,000 milligrams BID, as an outpatient in addition to Plaquenil. She did very well in this regimen and had stable disease for 6 years until she developed a red rash on her bilateral extremities. As you can see here, her rash was on her extensor surfaces of her elbows. She was sent to dermatology, where she was found to have biopsy-proven psoriasis, for which she was treated with topical glucocorticoids. Currently, this patient is doing well on hydroxychloroquine and belimumab sub-Q injections, which were started for arthralgia and alopecia. Her mycophenolate mofetil was subsequently stopped once her cytopenia is resolved. This is a patient who started with discoid lupus, then evolved to alveolitis and macrophage activating syndrome and was acutely ill in the hospital. She then developed psoriatic lesions, and now she has stable disease with alopecia and arthralgia, just showing how much of a clinical spectrum systemic lupus erythematosus patients can display.